All right, good morning. It's Friday, which is a good thing. And this is Senate Health and Welfare Committee on April 4th. This morning, we're looking at two bills, 266 and 238 that we've looked at previously and getting testimony to help us move along. And then we're going to hear back on a report or an update on some work that we did last year relative to provider safety. And it does relate somewhat to what we heard on the bill yesterday on violence in the workplace. Some good things to look at this morning. We're starting out with H266 and Colleen, is it Myman?
Yes, I am here, and I apologize that for some reason my camera is not working this morning, but I am here, definitely.
Sometime we'd like to see you for real.
I'd love to. I'm going to be up there next month, but just not right now.
All right, fine. So that's good. So why don't you introduce yourself for the record, and then we're going to go around the table and introduce ourselves, because we have a couple of folks who don't know us in the room on the screen. So we'll start here, Senator Hart.
Yeah, Senator Larry Hart, Orange County.
Hello.
Sam Douglas from Orleans County.
Jenny Lyons, Chittenden Southeast.
Martine LaRocque, Chittenden Central. Ann Cummings, Washington District.
Okay, so good morning. Do we have testimony from you on our webpage? Yes. Good.
There are slides. I can turn the slides on. I don't know what works best in your situation.
Yes, to put your slides up. That would be great.
Gladly. Unfortunately, it says I have permission to share. There you go. Hold on one second. Okay, hopefully you can see that now.
Yes, perfect.
Great. Okay. Well, let me introduce myself. My name is Colleen Myman. I have worked with the Bi-State Primary Care Association since 1998 as a policy person, originally with the Health Services and Resources Administration. Now I work directly for state associations around the country. Spent a lot of time on 340B issues. So thank you for the opportunity to speak with you today. Just as a reminder, let me see if I can move this thingy off here. There, okay. I knew I could do that somehow. You'd think after this many years, one would be good at knowing how to work on Zoom. Just as a reminder about FQHCs, I suspect you're all very familiar with them. They serve 1 in 3 Vermonters at 93 sites across the state, but they're really the backbone of the primary care safety net. They are intentionally located in areas where there's large numbers of medically underserved patients, and they intentionally seek to serve low-income patients. 70% of their patients are below the poverty line. They provide primary behavioral, dental, lab, preventive care, and they're run by their own patients and communities. They're never owned by a larger organization. So, and I'm happy to take questions as we go along. But what I'm going to talk about today is 340B is an extremely complicated program. And so I'm going to try to make it as understandable as possible briefly, and then talk about the need for this particular bill. So the name 340B actually comes from the section of the Public Health Service Act that created this program. The program wasn't even given a name. And what the program does is require drug manufacturers to sell drugs to certain safety net providers at a discount as a condition of getting their drugs covered by Medicaid and Medicare. So if they want to play in the Medicaid, Medicare space, they have to participate in 340B. 2 key points here. 340B discounts are funded entirely by drug makers, not by taxpayers. And in total, sales under 340B come to 7 or 8% of total U.S. drug sales. In terms of which provider types, which safety net providers qualify for 340B, about 85% of sales are for hospitals, DSH hospitals, disproportionate share hospitals, critical access hospitals, sole community hospitals, public hospitals, etc. The other 15% are grantees, organizations that get grants from HHS, such as FQHCs, Ryan White clinics, etc. The term used to refer to all of these providers is covered entities, but we all know that term appears in a lot of different statutes. So I try to just say 340B providers. Now, a question we get a lot is how big is the discount that manufacturers have to give? And there's two levels to that question. The only discount that they are required to give, that they have no control over, is this mandatory required discount. And it's 13% off of generic drugs and 23% off of brand name drugs. But if a drug maker raises a drug's price faster than inflation, then an additional penalty or discount is applied. It was a penalty meant to discourage drug makers from raising prices faster than inflation. Okay. And the faster a drug maker raises the price above inflation, the higher that additional discount gets, to the point that there are drugs where 340B providers only pay a penny, not because that was directly mandated by the feds, but because the drug maker increased those prices so quickly that the penalty discount got to be so high it wiped out the whole price of the drug. So drug makers have control over the size of the discounts. It depends beyond the 23%, depends on how quickly they raise their prices. So why was 340B created? And there's a lot of revisionist history going on right now. And so I think it's important to go back to what actually happened in 1992. The congressional report says very explicitly, the purpose of the program is to permit 340B providers to stretch scarce federal resources as far as possible, reaching more eligible patients and providing more comprehensive services. The points to note there is that 340B was created as a broad support for the safety net providers. It was not created to be a benefit directly to specific individuals on the prices of their drugs. Now, that doesn't mean that 340B providers don't offer discounts on their drugs, but the program is much broader than that. And you'll see that in a minute. 340B produces savings, for instance, for FQHCs that supports many, many of the FQHC's services beyond pharmaceuticals. Okay? But the intended beneficiary of this program was meant to be the 340B provider. It's not the equivalent of a drug discount card for a patient. So there's often a lot of confusion around how 340B generates savings for these providers. So I'm going to walk you through a short flow chart, and I believe Mary Kate has copies of that too. This is great. Okay. Let's say you have a drug where the regular price in the retail market is $100. Okay. And for simplicity, let's say the 340B price is $70. Okay. The way the program is structured under the HHS is that the health center can purchase the drugs at the $70, and they can have the drugs shipped either to a pharmacy that they own themselves, that's box 3 right here, or they can have them shipped to a contract pharmacy. So if you've got a health center that isn't big enough to run its own pharmacy or has a really big service area and its patients can't always get to the pharmacy, those sorts of situations is when you'll have a contract pharmacy. So regardless of which type of pharmacy it is, the health center owned or a contract pharmacy, the drugs can go to two types of patients, and that's why we have these crosses here. Let's start by going down the left-hand side, okay? Let's say the pharmacy sells this 340B drug to an insured patient. Well, the insurance company pays the FQHC or $100. And since the insurance company, just jumping down here, paid $100 and the health center paid $70, or the health center gets to keep $30. So they come out ahead. That's where the savings come from. The difference between the reduced price the health center paid and what they get back from the insurance company. Now let's just go back up to the other type of patient. Let's say the health center sells the drug to an uninsured patient, or in our case, it's very often underinsured patients, meaning patients whose deductibles are so high that they might as well be uninsured for purposes of getting drugs. Well, let's say that the patient who comes in to buy that qualifies for a sliding fee discount based on their income. And based on the health center's system for calculating sliding fee discounts, they determine that the maximum amount this patient can be charged for that drug is $20. Okay, I'm going to jump down here. Here we are again. The patient pays $20. So now you have a drug that the health center paid $70 for, and the patient paid $20 for. The health center is now short $50. So that's where these two streams, the two types of patients, come together. Well, for an insured patient, they save $30, right? If the health center sells that same drug to 3 insured patients, that generates $90 in savings because it's $30 per patient. They can then take those $90 in savings, and they can use that to cover the $50 that they lost over here by making this drug affordable for the low-income patient. And they still have $40 left. And that $40 goes to other services that the health center and its community-based board decide are of highest value to its community, its medically underserved community. And that can really vary, not just across states, but very much it varies across communities. So one health center in Vermont may use these funding for dental care. Another might focus on SUD treatment or school-based services or outreach, et cetera. So one point I want to make really clear is that for the 340B grantees like health centers, there is both a law and a regulation that requires us to spend every penny of those 340B savings for services that expand access for medically underserved patients. Now remember, that's not necessarily the same as spending them all for discounts on 340B drugs, but you take that extra funding and you use it for what is most needed by your community. So here's just some examples of what health centers in Vermont do. Dental care for the uninsured, mobile units, mental health and substance use treatment, transportation, translation, community health workers, et cetera. That's where the 340B savings go, in addition to making the drugs affordable for low-income patients. One point that cannot be overemphasized, 340B is truly essential to the financial stability of many safety net providers. I would put FQHCs in that category. I would put Ryan White clinics in that category. I would put critical access hospitals in that category. I'm not saying that it's not critical to other provider types. These are the ones I know best, and I feel comfortable talking about an entire group at once. I don't know enough about DSH hospitals, and I think there's probably more variation there. But for many safety net providers, critical access hospitals, FQHCs, this is essential to keeping our doors open. And if 340B went away, many safety net providers would definitely have to scale back their operations. And we've seen that already happening. And closing their doors entirely is distinctly a possibility. We've had several health centers have to close sites based on what's going on with 340B. So, any questions on the mechanics before I talk about the specific bill here?
No, it's great. Thank you.
Great. Okay. So the specific bill. So 340B is a federal program, and in an ideally functioning world, the Congress would step in and fix this. I don't think I'm the first person to postulate that Congress is not the ideally functioning organization we might all want right now. So what you can see here, and actually, you know what? I did this slide a couple of weeks ago, and I need to update it because it's changed a lot since then. We have multiple states. States have been stepping in big time. They stepped in, and you guys did this, to protect 340B providers from having to turn their savings over to the PBMs. Okay. Now we have states across the country that are stepping in to say no contract pharmacy restrictions. And I'll get into that in just a minute, but I realized I should have updated that slide just since this one. We have had two more states. This is the one on the right. Two more states have signed bills into law, and three more states have bills that are sitting on the governor's desk. And almost all of them, 4 out of 5 of them are very red states.
Which ones
Okay.
can you tell us? Connie?
North Dakota and Nebraska are sitting on, and North Dakota, Nebraska, and New Mexico are sitting on their governor's desks.
Okay.
And Utah and South Dakota have passed bills. So, and I am happy to send an updated map. I apologize for not thinking to update that last night. So, but yeah, so we're now up to 10 states with laws and 3 more just waiting for the governors to sign them. And believe me, these laws, Nebraska and North Dakota, people went, the pharmaceutical industry went way after them with box trucks around the Capitol and video ads and everything else. And they were still passed like 71-4 by the legislatures in these very conservative states.
Wow.
So happy to share that information. Yeah. Even after the sponsors, these bills were featured as Trump underminers and everything else, these bills still went through with very strong margins, veto-proof margins. So the biggest piece of this particular bill, H266, is that starting in the middle of the pandemic, some pharma companies, some drug manufacturers started saying, we're not going to ship 340B priced drugs to contract pharmacies. We're just not going to do it anymore. That expanded because they were able to bog things down in the courts. The HHS tried really hard to stop them, but they've bogged things. Pharmaceutical manufacturers have bogged them down the courts. We now have 37 manufacturers that ban contract pharmacies for hospitals and 24 for FQHCs. So I said, HHS has tried to stop them, but it has wound it up in the courts. And so we're now on 5 years waiting for this to be resolved. And this has led to significant declines in the 340B savings that health centers and others are able to accrue. And it has directly led around the country to health centers shutting down services and or closing specific sites, laying off staff. I was out in Iowa late last year, and they told me that 75% of their health centers in Iowa had to lay off staff because of the impact of these contract pharmacy restrictions. They could no longer afford the translation services, the SUD services, et cetera, that used to be financed through 340B once pharma decided to take this stand on their own.
Thanks.
The other issue that this bill would address is a rebate model. What happens right now, and has happened in the program's 35-year history, 33-year history, we buy the discounted drug. We buy the drug at the discounted price up front. Manufacturers are now saying, "Oh no, we want you to pay full price up front. Then we're going to give you this form you have to fill out with." I am not exaggerating. The last form I saw had 36 data fields on every single claim. You send that back to us. We'll look at and decide whether or not you deserve a rebate. And if you do, we'll send it to you. A real fox guarding the chicken house sort of situation there. Not to mention the massive cash flow and administrative burdens that would place on 340B providers. So this bill would explicitly say the rebate, no, you have to give the discount up front. You can't add all of this burden and make yourselves, leave the pharmaceutical manufacturers deciding when they have to provide this discount. Finally, my last slide, I just want to point out that FQHCs support transparency initiatives. You will hear from pharma that this program is not transparent. I think we all might have our own opinions about how transparent pharma is, but they're very happy to throw stones in other directions. We are supportive of transparency, but transparency has to be a full picture. They are coming forward saying, we just want to know how much 340B savings there is. If we're going to be reporting on 340B savings, we want to be able to tell our story of what we do with those savings. We want to be able to say, you take these savings away, then we lose these mobile vans, we lose these dental clinics, et cetera. Okay, so I want to be very clear. We are open to transparency as long as it tells us the full picture and it's not incredibly burdensome like this 36 data fields per claim sort of situation. So I'm happy to answer any questions you may have.
No, this is really helpful. Do you have a sense of the tariff effects that we are going to see, given the significant production of drugs in China and that come to us through China or Canada?
Yep, very concerned about that. I know that the reciprocal tariffs, the baseline 10% tariffs are supposed to apply to drugs, although I've seen stuff conflicting that. I'm still trying to get a firm answer. I know the reciprocal tariffs will not, but the baseline 10% tariffs, most of the active ingredients for our drugs, generic and brand, as you said, come from China and other places. This is definitely going to make drugs even more unaffordable for people in this country, as if it's not enough of a challenge already. Which means a program like this that makes sure that low-income people can get discounts becomes even more important. Without 340B, prior to 340B, I could count on one hand the number of health centers in the country who provided pharmaceutical services because they could not do it because of the price of the drugs. And if they keep eating away at this program, that's the world we're going to have to go back to.
Thank you. There's a lot, there's just so much embedded in what you're talking about. And this is, first of all, thank you for sorting out for us the way 34B works and the requirement for specific services and that any funds that our community health centers receive and how they are required to use them. So that's really helpful. Senator Gulick has a question.
Yeah, Colleen, I just wanted to thank you for that presentation. You made a really complicated system pretty understandable, and I really appreciate that. Thank you. I have a question, and I'm not trying to be cheeky or anything, but I just have to ask, like, why wouldn't we do this? What are the negatives if there
I think
are?
we'll hear from others.
Oh, I'm sure, but
You will hear that the program is not transparent enough. You will hear that pharmacies are located in affluent areas. I would argue that that is true, but it is because the contract pharmacies are in affluent areas. That's because there is a growing number of pharmacy deserts in this country. And so where else are you going to find a pharmacy? Okay. You will hear complaints that health centers have contracts with pharmacies all outside of Vermont. Well, once again, that makes sense because a drug or insurance companies and manufacturers make you go to specific pharmacies to get specific drugs or to get mail order drugs. So of course you have to go out of state. That means you're abiding by the rules of the insurance company, not that you're somehow or other violating this. I mean, I think the close to unanimous votes that are coming out over and over again from red states tell you something about the degree to which people think this is a pretty obvious a pretty obvious decision.
Yeah, thank you.
Yeah, I mean, the whole problem is determining where profits lie with healthcare needs. Yep. So it's always it's a struggle, isn't it? Thank you.
Mm-hmm. Absolutely. If you have just 1 minute, I have the updated slide of the contract pharmacy bills.
Oh, that would be great. Thank you.
Yeah, hold on 1 second. It's supposed to be pulling it up here. I'm clicking on it.
And will you send it to us?
Absolutely. Absolutely.
Okay.
And I apologize for not getting that. Let me just hit share one more time. Okay, share. Hopefully you can see that now.
Yep.
The red states are, North Dakota must have just signed it since I last checked. North Dakota is now in the signed group. Okay. Literally, I checked like an hour ago. Okay. All the blue states have laws in effect. The dark reds have them on the governor's desks. The orange have them pass through one chamber of the legislature at a minimum. The yellow have bills. And you can see in Idaho and Kentucky, the bills were defeated. In Kentucky, they were defeated. Yeah, it passed the Senate overwhelmingly, but it was defeated. They refused to bring it to the floor in Kentucky. It was kind of a legislative maneuver there.
Huh.
What
And
happened in
New
New
Hampshire.
Hampshire? Why did it die? Just
I'm trying to remember. Mary Kate, can you help with that?
I would have to check with my colleague. So Mary Kate Molman, Bi-State Primary Care Association, I would have to check with my colleague, but it just, the legislature just filled it very quickly. They have a very interesting way that they
Yeah.
manage bills on that side.
Yeah, they're different.
Very different.
Very different.
Okay.
Yeah.
And they're only in session, like,
Okay.
Yeah.
very
And
short.
every bill gets a hearing and it's like 2 minutes and then you're on to the next. And
It's probably too
Okay,
complicated.
well, so, from your perspective,
Mhm.
Colleen,
Yes.
in the states that have approved, or the role that hospitals have played in this and our critical care access hospitals have played in, testimony, have they given support from your perspective?
Critical access hospitals are very supportive. I would argue that they are as dependent on 340B savings to keep their doors open as health centers and Ryan White's and Soul Community Hospital. So they don't seem to have a national organization to this, a national voice to the same degree.
Okay.
Most of the concerns you will hear raised have to do with dish hospitals. But they are, I mean, there's not a provider group in the country that ADAPs or AIDS drug assistance programs are function differently, but any direct provider, all the direct providers are very supportive of this.
Okay.
We're just the ones leading the charge because 70% of our drugs go through contract pharmacies because we serve large service areas. You know, people have to drive a long way, et cetera.
Thank you. I think, well, probably rural states, with the smaller hospitals and community health centers, become really dependent on some of the funds here.
And if I may, may I get some?
Mary Kate?
Thank you. So Mary Kay with Bi-State. I just want to add one thing to Colleen's comments. The Arkansas law, that was one of the first ones on the book, that has been upheld by the Supreme Court.
Oh,
The Louisiana was sort of the second to come behind Arkansas. That I believe, Colleen, correct me if I'm wrong, but that's been upheld at the appellate level.
It has been, it hasn't been taken to the Supreme Court yet. The Supreme Court that just said, no, we don't even want to hear the case about the Arkansas law. It was, you know, we heard you had 2 bites at the apple at the appeals court level. No, we're not going there. The only time one of these state bills has met a challenge in court was a West Virginia law bill, where I would argue that the lawyers did a very poor job of representing what the bill did, and the bill was faulted for doing something that it didn't actually do.
okay, thank you. And our ledge counsel, Jen, do you mind?
Oh, Jen Harvey, legislative counsel, just clarifying that I believe in the Arkansas case, the Supreme Court declined to hear the case, which is a little different than upholding it. It's sort of functionally a similar result, but there is no case law out of the Supreme Court upholding.
Oh, and the appellate level was in Louisiana?
I only found that at the district level. I think.
District level?
The district
Okay.
level.
Appellate level, I know it's been in the 8th Circuit, which is Arkansas.
Oh,
Right.
Got it,
I think
okay.
if Fifth Circuit is Louisiana, I think it was just at the district court level.
okay.
And it's fairly recent, so it may be appealed, may not.
All right. Well, there are enough states there now that make it interesting. The will of the people is which states were. All right, thank you. Is there anything
Okay.
else that we should know?
Oh, one other argument you might hear is that this law will increase cost on employers. You know, manufacturers and PBMs, the pharmaceutical benefit manufacturers, the last decade or so have arranged this deal of rebates. I'm sure you're familiar with the whole rebate thing, which very much obscures the real price of a drug.
Yeah.
And the newest argument is, well, we don't, you know, they agreed not to put the those voluntary rebates on 340B drugs. And so now they're saying, well, every time an employer pays for a drug that was under 340B, they don't get the rebate. And so therefore it's costing the patients more. My response back to that is, number one, you're not sure those rebates are actually getting back to the actual patient. And number two, those rebates are something, it was a voluntary mechanism agreed to by two for-profit entities, manufacturers and PBMs, to increase their market share, okay, in recent years, as opposed to something established by Congress to support the safety net that is absolutely essential, that it's been in place for 30 years. So I am happy to provide more information if you do end up hearing that argument, but I think there's a lot of weaknesses to it.
Thank you. We may reach back to you, so we want a full picture of whatever we hear, so this is helpful. Thank you.
Absolutely.
All right, and please do send us that last updated slide. It's great.
Absolutely.
All right, good. So next, we have Calvin Pugh, the 340B Policy Director of the Community Access National Network. Calvin, thank you for being here. And do we have your testimony?
Yes, ma'am.
All right, good. Do you want to put slides up, or I haven't looked at it yet?
I don't have fancy slides, I'm afraid.
Oh, nuts. Okay, but that's okay. You don't have to have them. So we will follow along with your testimony on our iPads. That's helpful.
Wonderful. And I do appreciate the previous speakers highlighting the way 340B works, so I don't have to repeat it. But I appreciate you having me. Again, my name is Calvin Pugh, and I'm the 340B State Policy Director for the Community Access National Network. It's CAN's mission to define, promote, and improve access to healthcare services and support for people living with HIV and viral hepatitis through advocacy, education, and networking. And I respectfully come before you to urge caution. To expand 340B contract pharmacy arrangements without limitation, particularly limitations necessary to ensure proper mechanisms to ensure the program appropriately serves patients, especially those living with HIV and other chronic conditions. Our concern is around hospitals. Vermont 340B hospitals already have 855 contracts with pharmacies, which 76% of those are out of the state. Now, 340B is a vital source of funding for fairly qualified health centers, the clinics and places that provide vital care to communities who need it most. It provides essential funding for community oncology clinics providing cancer treatment far from large cities. It also supports the work of the AIDS Drug Assistance Program, which is the only named grantee in the 340B legislation, making life-saving treatment and services possible throughout the great state of Vermont. We are encouraged by the reporting requirements for hospitals, we'd like to remind the committee the definition of community benefit has not been updated since 1974. 93% of Vermont hospitals are below average levels of charity care, earning 10.4 times more in 340B profits than is spent in charity care. Lots of providers, pharmacists, and payers are unaware. They'll say that they are unaware of the value of a discount, preventing them from applying these savings to patients' out-of-pocket costs. However, this claim is false. The truth is many 340B entities employ third-party administrators, TPAs. These TPAs are vertically integrated with pharmacy benefit managers and contract pharmacies. TPAs provide electronic medical record systems integrations, allowing providers to know the approximate or exact value of revenue a specific medication will generate while seeing a patient before the patient even reaches the pharmacy counter. In fact, these TPAs advertise services across different platforms to maximize 340B revenue capture. And again, I'm speaking about hospitals, not FQHCs. But we believe that patients deserve to benefit from reduced acquisition costs. Hospitals who participate in the program also generate revenue by acquiring independent physician practices, especially oncology and specialty care, converting them into hospital outpatient departments. This allows them to buy drugs at a discounted price, but bill insurers, including Medicare and state plans, at full price. As large hospital systems continue to consolidate, they dominate regional healthcare markets. They reduce competition, which drives up costs for all of us. Patients in Vermont are already facing higher costs due to reduced competition, according to the Burlington Free Press. Many rural hospitals are not eligible for 340B because they don't meet the disproportionate share hospital or DSH hospital threshold. Meanwhile, urban 340B hospitals acquire specialty care providers, drawing patients and revenue away from rural facilities. In March, the Wall Street Journal reported a novel form of program abuse, including involving the diversion of 340B savings away from needy patients to gainfully employed individuals. The article detailed several entities selling pharmacy benefit services that funnel employees to hospitals to receive that discounted 340B price. However, hospitals are participating in these arrangements to expand their customer base and receive fees for dispensing prescriptions. H.266 reporting requirements is an encouraging first step to require hospitals to share details regarding their participation in the program. We encourage the legislature to define community benefit to ensure that savings are being used in line with the original intent of the 340B legislation, to stretch those federal resources to reach more eligible patients and providing more comprehensive services. The abuse in the 340B space is not undocumented. The examples of mismanaged housing programs in Los Angeles, at the University of Miami, paying their head football coach, or in the latest issue of abuse, an $8 million Super Bowl ad. To be clear, we support a strong 340B program. When it operates as it's intended, safety net providers thrive, and vulnerable communities, families, and individuals gain access to healthcare they otherwise might not have. We're happy to have any discussion on instituting appropriate guardrails into legislation that would strengthen the program, shield good stewards, and hold accountable bad actors within the appropriate limitations of state powers associated with this federal program. I urge you to put patients first, before third-party profiteering, before greedy C-suites. And I will stop there. But I thank you for your time.
Thank you. Overall, your concern, what I'm hearing, your concern from your organization, and you didn't introduce your organization. If you wouldn't mind just telling us what the Community Access National Network is and who it represents.
Yes, absolutely. So it's CAN's mission, Community Access National Network's mission, is to define, promote, and improve access to healthcare services and support for people living with HIV and viral hepatitis. And we do that through advocacy, education, and networking. We are primarily a patient organization who works in advocacy, putting patients first.
So how do you get your support? What are there organizations that support you? It sounds like you've just got individual patients supporting you, which I'm trying to understand.
Yeah, we have a large network of patients that we work with across the country.
But who supports you economically? Where are your resources coming from?
Well, through different pharmaceutical companies or manufacturers, also from other outside organizations like biomedical.
Okay, thank you. That's helpful. And the concern that I'm hearing from your organization is that hospitals are taking advantage of the 340B and making a huge profit.
Yes, ma'am.
Well, so in our state, if that were the case, we wouldn't have 5 hospitals in the red. So that is an interesting. So in our state, it might be slightly different from what you're seeing in larger states or different other places. But so, and then what is your comment? I couldn't pull up your testimony because something's going on with my internet, but your testimony with regard to rebates, did you have any comments on rebates that I missed?
I did not.
Okay, all right, thank you. Committee questions for Calvin? No, we're good. Thank you very much, Calvin. Thank you for taking the time. We greatly appreciate it.
Thank you. I appreciate your time.
All right, good. All right, and we have Charles Becker from the Healthcare Advocates Office. And Charles, thank you for being with us. Do you have slides or testimony that can?
Yes, Chair Lyons, I do have slides. First, are you able to hear me? I just want to make sure I'm all set up correctly here.
Yes, it's great. Thank you.
Okay, great. Yeah, and I do have slides. I'm sorry I did not send them to you ahead of time. I will send them to you sometime this afternoon before the end of the day for
Okay.
sure, so you can have them.
Perfect.
Before I get started, I just want to make sure I have about 15 minutes of things to say, and I know that you have a full slate of people coming up at 10 o'clock. And did you want to break before then? So I'm just trying to gauge my timing.
Go right ahead.
Okay.
Well,
All right.
we are on.
Okay. Let me get my
We
slides
have-
up.
We have time. We have
Okay,
a lot
very
of time. This is
Very
good.
good. So my slides should be up. Let me make sure they're maximized. Okay. Are you able to see them?
Not yet.
Uh-oh. Oh no.
We can see you.
Okay. Why is this not working? You're still not seeing my slides?
Still not seeing your slides.
Okay, let me try something else. This is unfortunate.
Yeah, sharing. Yeah, sharing.
Okay. At Legal Aid, we use Zoom, Teams, and not Zoom. So my apologies. Yeah.
Do you want to go back? Oh, but you are on Zoom now, so.
Oh, I think.
There we
Okay.
go.
Do you see my slides now by any chance?
Yes.
Okay.
Very
Okay.
good.
All right.
We can see you've got there. That's good.
Do you- oh.
We saw your
You-
notes as well, but you may not.
Okay.
You don't want to see your notes.
Now I can't see my notes. This is going terribly. Are you able to see the slides so we can just move forward here? Yes. Okay.
This is fine, and we don't demand your notes. That's good.
Okay. I'm sorry. Thank you. So I've wasted enough time. Let me just dive right in. So regarding Section 1 of this bill, the contract pharmacy protections, on behalf of the HCA, I just want to say that the HCA cautiously supports the contract pharmacy language in Section 1. And let me clarify what we mean by cautiously support. So this is a different reason for caution than you heard from the previous witness. The HCA understands that 340B revenue is a vital lifeline for Vermont healthcare providers. We know that Vermont providers rely on contract pharmacies to maximize their 340B revenue, and that restrictions on contract pharmacies by drug manufacturers have reduced that revenue. We know this hurts Vermonters. But the caution we want to bring into the picture here, and we've heard some of this already, is that the contract pharmacies issue is a contentious issue, and has been ever since HRSA issued guidance that covered entities can utilize unlimited contract pharmacies a decade and a half ago. There has been litigation, multiple rounds of complex litigation, some of which has gone in the direction of the manufacturer's position, allowing restrictions on contract pharmacies to continue. And then in response to that, states began to pass these contract pharmacy protection bills, what we have here in H266. And as the first witness showed, those now 10 or 11 states that have passed this language. The first 8 states that passed this version of the bill of H266 that's before you, those first 8 states all got sued by pharma and or the drug manufacturers, to be more precise. And while that litigation has mostly gone in the state's favor, there's one outlier now, a significant outlier, West Virginia, which creates the possibility here for there to be a circuit split, which might then, we heard from Jen Carby that the Supreme Court denied cert for the Arkansas law, meaning that law stands, but the Supreme Court hasn't yet decided on that case. And this West Virginia case might open up the window for them to say, we want to weigh in on this. So that's why the HCA cautiously supports Section 1. This is a litigious area, but while this window is open, we do think it's important to put our Vermont providers on the strongest possible footing with respect to 340B and to give them this contract pharmacy protection language. At the same time, we see this as a valuable opportunity for the state of Vermont to learn more about the impact of 340B on our very fragile state healthcare system. And that's the purpose of Section 2 of this bill, to provide transparency into the 340B program here in Vermont. On the House side, we had a lot of questions about why is this something we want to do? Why is transparency important? What kinds of questions are we trying to answer? And if you can see my slides, I've put up just a few of the questions that I think would be important for us to answer with 340B transparency. I won't go through them all. I'll just go through some of them. You know, how much revenue are we even talking about? And you heard the first witness use the word savings, 340B savings. You heard the second witness use the word profit. I'm going to go ahead and use the word 340B revenue. How much revenue are we talking about? System-wide here in Vermont at the hospital level, we're certainly talking about $50 million or more, but we don't know. And that's one important reason why we should ask. A second important reason why we need transparency around 340B is, where is this revenue coming from? Who is paying that $50 million plus? We did hear our first witness. I think she said something to the effect that this is funded by the drug manufacturers. I would take issue with that presentation, with that position. This money is coming from us, from ordinary Vermonters. This is revenue that's being paid for first by ordinary Vermonters, some of whom are struggling financially through their cost sharing, and most impactfully upon Vermonters with high deductible health plans in their deductible phase. And then that revenue is being paid by our Vermont health insurers who are struggling. And then that revenue is being paid for by our local Vermont businesses that self-insure, many of whom are struggling. And then it's being paid for by our government payers as well, Medicare and Medicaid. And I think it might be fair to say they're struggling as well. So this is money that's coming from somewhere. And the drug manufacturers are just giving the drugs at a discount. The way the money is made is by then selling those steeply discounted drugs to patients. And that's where the revenue comes from. Quickly, a few other questions that I think are important to answer here is, how much are hospitals paying other entities to maximize their 340B revenue? When 340B was small and limited to in-house pharmacies or a small number of contract pharmacies, hospitals managed their participation on their own. Now they're paying vendors to maximize their 340B revenues. Who are they paying and how much are they paying them? I think these are important questions. There are others. I see time is limited. I want to move on to some of our suggested languages for improvement to section 2. So I'm going to move on to my next slide. We have here some recommendations for how to, in our opinion, improve the language that came over to you from the House. So section 2, paragraph 1. Paragraph 1 in the bill before you calls for hospitals to submit annually to the GMCB, the Green Mountain Care Board, their annual estimated savings to the hospital from participating in 340B. And it provides a method for deriving that estimate as comparing the acquisition costs of drugs under the 340B program to group purchasing organization pricing. Our recommendation is to restore the original language, which actually came from a different bill, H202. We took the transparency language out of H202 and put it into 266. We'd recommend restoring that original language, which is here on the right side, and to make some improvements on that language, which I've highlighted in yellow. Our reasoning here is simple. If the goal is to have actual transparency into 340B, the language that was passed by the House is not going to give us that. If we want to know what hospitals' actual revenues are from 340B, we should ask that question. And that's what this language would do. It would require hospitals to report the aggregated acquisition cost for all prescription drugs that the hospital or any entity acting on the hospital's behalf obtained through 340B. In other words, to provide the hospital's actual acquisition costs for 340B drugs. And next, in the second paragraph, the language would require hospitals to report the aggregated payment amount broken down by payer type and further separated into patient cost sharing and third-party payer contributions. From those two numbers, what hospitals were reimbursed minus what they paid, we can know what 340B revenues actually are at hospitals, and we can know the relative burden of 340B on Vermont payers and on Vermont patients. I have here notes on some of the pushback, some of the feedback that we received from hospitals in the House. I'm not going to go through all of those in the interest of time. I'm going to submit it in my written testimony at the end of the day. Essentially, they made comments about this being burdensome, that the information could be more easily obtained from elsewhere, and that in the case of infused drugs at hospitals, that it might, with bundled payments, that it might be impossible for them to provide that information. We have responses to all of those concerns, and I'll submit it in my written testimony at the end of the day. I'm just going to move on. We have one more substantive recommendation and then a few miscellaneous recommendations. You see before you here, section 2, paragraph 3. We recommend adding to the end of that paragraph a requirement that hospitals list who their 340B vendors are and briefly describe what those vendors do. We're not asking for the specific payment amounts to these vendors. That would still be aggregated, and we're not asking for any proprietary information here. This should be simply, what vendors are you utilizing to maximize your 340B revenue, and what are they doing for you? And then on the final slide here, a slew of miscellaneous recommendations. Section 2, paragraph 4, the number of claims obtained through 340B. You're going to hear from GMCB later on that they don't think that this is useful. We agree and would urge you to go with their recommended improvement for a suggestion for improving this language. The same for section 2, paragraph 5, a description of the way hospitals use their savings. GMCB, I believe, is going to present to you some suggestions for how to improve this language. We agree with their suggestions and would encourage you to consider them. This third bullet point is also a GMCB suggestion. We agree with it. Require that the hospitals attest that the information that they're providing is true and accurate. And then the final bullet point here is it's our own idea, and unfortunately we have not yet had the chance to run it by GMCB. I'd certainly be curious to know what they think and what you think as well. Something needs to be added to this language, I think, that would give, and it could be as simple as adding in a form and manner prescribed by the board to the introductory paragraph to section 1, something just to make it clear that the GMCB has flexibility, that they are empowered to interpret and clarify what this language, this reporting language means in case there are questions and ambiguity. I would also encourage you just quickly to look up the Minnesota 340B transparency report. The state of Minnesota has already done this. The language we're proposing that you include here is based on the Minnesota model. Minnesota's been doing this for a year. I think we can learn from their experience, including how to deal with the infused drugs issue. And that's all I'll say. I can see it's 10 o'clock, and if you have time for questions, I'm happy to answer any.
No, thank you, Charles. And listen, this is helpful. Did you bring all of these suggestions to the House when you were providing testimony?
In the House, the language that was before them was this language that we're proposing, and they were persuaded to go in a different direction. And I will say, it was getting close to crossover. There was not a lot of time, and I know that there was urgency to move this bill. And I don't want to say we were rushed, as I'm rushing through my presentation here today. I don't know that we had a chance to have a full and robust discussion about this. So when I submit my written testimony, I'll try to illuminate a little bit further about why we think this is important to to maybe try the Minnesota model instead of the Maine model, which is the language we ended up with.
Okay, thank you.
Thank you so
Right,
much.
well, so obviously, when we go through the bill again, and we do some markup on the bill, we're going to have a conversation about what seems appropriate going forward. But appreciate your
Absolutely.
suggestion.
Thank you for having me in today. Thank you.
We've got healthcare advocate is here. Mike, you want to?
Can I just add one thought on section 1 of the bill, and Charlie, please correct me if I go astray here. We just thought it was important for the committee to understand the potential likelihood of litigation as you're considering this action. And given the pattern of suits, not weighing, we're supportive of the language, not weighing in on whether we would be successful or not, recognizing that the Second Circuit has not seen litigation. And if there is a division between circuits, it would not be surprising if there was litigation. So as you consider this, I think that's.
And yet Maine has had its law in place. They haven't been challenged yet.
The main law is transparency. It's not dealing with contract pharmacies. And thank you for bringing it up. That's a very important point. The main language I was referring to is strictly a parallel to section 2. Section 1, I don't think Maine is on the list of states that have done the contract pharmacy protection language.
Okay, thank you.
Mm-hmm.
Senator Douglas has a question.
Yes, Mr. Becker, earlier in your testimony, you mentioned and you're talking about it right now, all the lawsuits have been brought up, that the states are mostly winning. Obviously, we don't have time to talk about it right now, but would you mind sending me more information by email about those cases and what the arguments were for bringing those lawsuits?
Yes, yeah, I can do that. And I'll share it with the rest of the committee as well. It may not happen today, if that's okay. Monday at the latest, okay? Because, okay. Would that be okay?
Okay, thank you.
Okay.
Any
Thank
other
you so much.
questions? We're good. Thank
Okay.
you. I do have one question. So she left, but
No, I'm here. I'm here.
There he is.
Okay, yeah.
Well, you didn't leave. So you're talking about the reporting requirement for the hospital, and is there a thought about how much that would cost, and in terms of preparing and gathering data on that? I know we'll hear from the hospitals, but from your side of the fence, what are you seeing with that?
A cost, I wouldn't even want to hazard a guess at what it might cost the hospitals to comply with these reporting requirements. I would make another pitch for Minnesota and their reporting report, and just say that Minnesota heard from their hospitals, oh, this is going to be burdensome for us to do. But in the end, 90%, they had an over 90% compliance rate with their reporting requirements. So, I mean, that must tell you something, right? If it was a burden, it certainly wasn't insurmountable.
Okay, thank you.
Mm-hmm.
All right, so we're going to move on. We will not take a break. We might take a break in a little bit, but we're just going to move on to our next bill, which is 238. Is Matt Chapman coming in online? Or
He's in the building.
Probably in the hallway.
He's in the building.
Do you need a break? No. So. He's in the building. He's in the room. There he is.
Am I going right in?
You are. All right.
well.
I know. So, and I'm asking you before you even sit down, are you able to stay with us while we go through the bill?
I can.
I don't want to.
Sure, no, I honestly, I don't have anything else planned this morning, and I'm happy to stay with you.
Thank you.
So for the record, Matt Chapman.
And just as a remind us what the bill is. Because
Sure.
we just came up with the 340B pharmaceutical bill.
I am more than happy what I may do is I may also warm my laptop just so that I have my notes in front
Go
of me
ahead,
while I'm
get yourself
introducing.
organized. Or not.
So for the record, Matt Chapman, I'm the Director of Waste Management Prevention at the Department of Environmental Conservation, here to speak on H238, which is a phase out of PFAS in certain PFAS containing products. So we're really looking at three products and the way H238 came over from the House. It's dental floss, cleaning products, and fluorinated containers. So I'll just sort of start my testimony with last year, the legislature passed Act 131, which is another set of helpful exceptions to PFAS in consumer products, phase outs of PFAS in consumer products. That legislation required that the agency work with the Agency of Natural Resources works with the Department of Health, the Attorney General's Office, and the Agency of Agriculture, Food and Markets to come up with a more comprehensive plan on how to phase out PFAS in more than just sort of the product by product list and start moving towards a sort of more comprehensive regulatory approach. In my written testimony that I've already provided to Kiki, I have a link to that report and to the proposed legislation. The House, after consideration, elected not to take the agency's recommendations and move forward with what you see before you. I just to sort of preface my comments. We still support what we put in the Act 131 report. We think moving to a broader set of restrictions on consumer products is important. I also understand that we take one step at a time, and we're supportive of what the House did with a few comments. And I think it probably is worthwhile for me, before I get into the specific comments on 238, to sort of speak to the importance of phasing PFAS out of consumer products. It is incredibly expensive and incredibly difficult to deal with PFAS after it already gets out into the environment. And what we end up doing is having to put treatment on municipal wastewater treatment facilities, municipally owned public drinking water supplies, or landfills, thereby passing all of those costs on consumers and ratepayers, as opposed to putting the focus on the manufacturers who have the capacity to come up with alternatives other than PFAS so that we don't have to deal with it in the first instance.
So I am, I opened up your draft. We have not gone through the draft legislation, nor did Michael. Did we look at a comparison a little bit?
We did a walkthrough, but
of the legislation that was proposed and
no, not of what A&R gave in their Act 31 report.
yeah.
I mean, it's materially, I want to say it's materially different than what passed the House. And, I would say it's not something in sort of a short period of time that I could just run through.
No, I don't want you to do that. I'm just thinking about what we might want to do going forward, just to see the differences. We can read it individually.
Sure.
No problem with that. We might ask Michael to help us out a little bit, but not. I understand the work that's already gone on in the House Natural Resources.
Understood.
Yeah.
Understood. So just getting sort of to the comments, of course, if I can get my computer up, but I'll start with the first one, which is basically we're supportive of changes the Attorney General's office offered with respect to intentionally added. I think those make sense.
Okay, that's good to know.
And the other is just sort of stepping back. I know there was a lot of conversation with the Attorney General's office and around fluorinated containers and sort of what they are, what they're used for. And so basically fluorinated containers are a container that they're most often plastic. They are coated with it. Normally it's like a fluorine gas treatment on the inside of the container that is to either make the container more stable or the materials not impact the container. So we know of its use in pesticides and some of the contaminant issues that have happened there. So basically the concern is that the fluorine treatment on the container results in PFAS creation in the product that is stored in the container that ends up resulting in sort of larger impacts. So, I mean, I guess just again to sort of context set, based on our research, and we've certainly asked fluorine treated container manufacturers and users to provide us with more information. And I'll just want to be transparent. I've gotten a dearth of information from them. Based on our understanding, consultation with other states and research, we think that there are adequate alternatives out there to fluorine treated containers. They are more expensive. I don't want to sugarcoat that, but they are.
We're all looking at tariffs. Right?
Well, that's right. And so, and there are not, based on work that both the Agency of Transportation and the Agency of Natural Resources has done, we don't believe that there are restrictions or requirements under DOT shipping regulations as they relate to the use of fluorine treated containers. So again, we don't believe that those regulations require the use of fluorine treated containers. So that's a little fluorine treated container background.
Thank you.
I guess I will just say the getting into the legislation itself and the approach the House ended up taking with fluorine treated containers, the agency strongly opposes the use of a currently unavoidable use exception to the fluorine treated container requirement. Again, I think there are two basic reasons for that. One is we don't think it's necessary. But I think just as important, I think from my perspective, that's a technically significant and cost intensive process to go through. And the bill does not contain the fees, the budget, or the people to do it. And we're not advocating that it do. We don't think that it should be here ultimately. So, part of the reason we have looked at using currently unavoidable use exceptions sort of as we go down the road to the broader consumer products, but it's the way we always approach that is doing it regionally in the context with a clearinghouse when other states with more resources have sort of picked up some of this work. And that's not the case now. And we don't think that we have the capacity to do it at this time. So I think that, and again, trying to be.
And you've got a comment in here about the EU and its ban.
Sure. I mean, so two things. If the committee continues to have concerns or the industry continues to have concerns about the use of or the prohibitions on fluorine treated containers, I think there are two options the committee can consider. One is the EU sort of has a global products ban in 2030, and fluorine treated containers should be included in that. The state of Minnesota's product ban goes in 2032. So I think it's our expectation that there will be suitable alternative options available for those containers. I think they're there now. I feel almost certain that they will be there then. And happy to answer any further questions the committee has. Or, I mean, and I guess I'll just loop back again, listening to testimony from Dr. Levine and the Attorney General. Talking about treatment in the context of PFAS. So when we're talking about drinking water, there are numerous treatment options available. Most often it's GAC, granulated activated carbon. It's basically a carbon treatment unit. It's not dissimilar to like the Brita filter or the pure filter you put on your faucet to treat your drinking water as it comes in. There are better models than there's a wide range of models that are out there. Some of them are more efficient than others. So, but most of them achieve some degree of efficiency in treating PFAS. And so when we get into treating it at a public community drinking water, we're either talking about larger vessels that use carbon, or there are also sort of ion exchange or reverse osmosis, other technologies that are out there that can be used for treatment.
Clear water has.
Exactly. I mean, all of the technologies, they are available for you to put in your house today, and sort of the some of them are more expensive, some of them treat more contaminants, some of them are right.
So one question for you, and because I don't remember what everything in the report, but in terms of pesticides and seeds that may be contaminated or coated or included?
Sure. So there was certainly, the toxicology expertise is not housed at the Agency of Natural Resources, and that was really Dr. Owen and Dr. Breyer, the new
And
ag toxicologist who's working on issues. And they had extensive conversations around the approaches that are being taken and whether pesticides are or not, would or would not be covered, how they're affected. And I guess I will say, Pam from the from the Agency of Agriculture has worked in this space extensively, both in the states of Maine and the state of Vermont. And if the Breyer said you should feel free to have her expertise. I mean, I think part of the challenge with the definition of PFAS that we are currently using, the OCED definition, is that based on the most recent studies, we're looking at about 7 million different compounds that meet the definition of PFAS. And so, and remember that we have the ability to test for about 30 to 40 of those in the laboratory, right? So there's a large universe of PFAS compounds out there that are existing, but we can't see them with the analytical equipment that we have.
Right. I mean, we did send some analytical equipment to Virginia about 15 years ago. I forget when that was. We broke up the DEC. Do you remember? Yeah.
The DEC lab?
Yeah.
Well, I mean, so we have the Vermont Agriculture and Environmental Lab in Randolph, and they have the ability to test for, they just are bringing online the ability to test for PFAS. But I mean, our labs are more like, they're not, I don't want to in any way disparage it, they are sort of workhorse labs, not sort of research labs. So they're not sort of cutting the edge of the world as far as what we can test. Yeah. So
I know it's an art and a science.
Agreed. Yeah. All right.
Questions for Matt Chapman? Again, thank you for all your work.
You're welcome.
Because you are our expert and we know that. And we'll, in some way, I think each one of us will want to go through the bill as you proposed it in your report, as a result of the report. See if there's anything there that's useful in 238. Appreciate your very definitive comments on the bill.
You're welcome. Thank you.
Great. All right. So Chris Doobie is here. Thank you.
Thank you, Madam Chair. So I will email Kiki some documents.
Oh, good. Thanks. Yeah.
That they're putting together. So I'm going to give you, I don't only have like a couple minutes, so I'll give you a high level overview of our concerns with the PFAS and the H-250 bill. Hopefully you can morph it into this bill.
Okay, so you're talking about a bill that's currently in the House that has.
Yes, it's in the Human Services, and Chair Woods is supposed to talk with you on that. I don't know if she has.
Yeah.
To get it off her and give it to you, and hopefully we can make it work. And I've been talking with Ashley, Senator Bruce.
So let me stop you here and ask Michael, is that a bill that you put together?
No, that was Katie.
Katie's bill? Okay, well, we'll have to have her come in and go through.
Yeah, and basically that bill, every bill, PFAS bill has been out there, just for historical perspective, has always exempted protective clothing. Yeah, firefighting in specific.
Yes,
Reason why, there's no
we know.
safe alternative. So that's, I'm gonna tell you, that's a lie. I mean, if this progresses, we have more testimony. I'd love to bring in somebody from the IFF. He's hopefully be the guy I want, a captain out in LA County that is actually a chemist, because he didn't believe the info that the chemical companies or textile companies were providing us on this. So real broad overview. So cancers in the fire service it's an epidemic right now. The IFF, I'm going to give some disclosure. I'm only talking about the career side. The IFF, I don't know what the volunteer does. I don't even know if they have numbers. So last year, 2023 to 2024 Memorial, 195 names were on the wall. 75% were occupational cancer. Meaning people got it while they were working full time, ended up getting off the job and dying because of that. And that's interesting because in a time when fires are down nationally, cancer rates are going up. We've developed a direct link between our gear that we wear, the PFAS, and to the extent some of the brominated flame retardants that are in it, as being one of the leading factors as to that. Now, granted, we're exposed to a lot of toxic chemicals when we go to a call. But our stance is that our gear should not be one of those things that we're exposed to. There has been advances with fire gear through the years. You'll see studies out there. One in particular comes out of North Carolina State that a lot of people are sold on. The individual that does that has a tie to the textile industry, so it's going to be skewed to make you think that you need to have PFAS in your gear. He'll show you a plain test on an outer shell. Well, the reality is most manufacturers now are selling outer shells that are PFAS free. The biggest layer, so fire gear has 3 layers. There's an outer shell, which is what you see in the black, or whatever. And that basically protects us from the flames and abrasion and stuff like that. Then you have a moisture barrier and a thermal barrier. Most thermal barriers now have removed the PFAS, but still found at high levels on the moisture barrier. That's because of a product they use that's similar to Teflon. We're trying to push the industry to change that. One of the factors we're seeing is that the testing that the NFPA uses, National Fire Protection Association, as a vertical flame test. Our argument is that test is relevant on a layer that's not exposed to flame. So if this bill gets attached, there's 2 things I'm going to ask of this committee. There's one that we add the term brominated flame retardants in there, because that seems to be a workaround the industry is using for that moisture barrier to meet the vertical flame test. And I'm working with California. They're proposing legislation that's going to also, in their wording, outline that NFPA performance test, saying it's not a realistic test. Let's test the ensemble as it's all together, not this piece, and this piece, right? Because there are layers that are not going to be exposed to flame. So why are we doing a vertical flame test?
Is the moisture layer the closest one to the skin?
Depending on how the garment is made, I think it is, yes. So that's where we're getting that high absorption rate of that. So I guess in closing, I would say real quick that we feel that firefighters should be driving the whole question on gear. It shouldn't be industry saying that you've got to have this. There are alternatives out there. You're going to hear that, well, they're not the same. Well, of course they're not. I mean, we could line our gear with asbestos to make it fireproof. Is that the right path to take? No. There are tests out there. A lot of the issues we have is when it comes to PFAS, is some of the NFPA standards. We are working on it on the national level with the IFF to change that test to make it more realistic to the environments we see. You'll see a video out there in May where they spilled gasoline on the gear. Well, I don't care what you have for gear, that's the gasoline's burning, it's not the gear. So, but people will see that, think that it's the gear, and that's how the industry is selling the product. So, I mean, I could go on and on, but for the sake of time, as you other ones, my request is that you consider adding that H250. I'd love to work with you, and like I say, I'd like to add, it says PFAS, but also brominated flame retardants, because talking with my guy yesterday, it seemed like the industry is using that as a workaround.
Yeah, we did deal with brominated flame retardants several years ago. You know.
But I'm hearing that that's what one of the industry's workaround right now is they're adding that in there. A lot of it has to do with the vertical flame test. And I'm working with the legislative agent for the California Professional Firefighters to get her language that they're putting in their bill that outlines that NFPA test, if it's going to be sold in Vermont, it needs to be tested as an ensemble, not A, B, and C. So that way you're getting a true test, not one that skews it to the manufacturer. And like I say, this is a far-reaching issue. I told you before that it's not just the cancer. I've done my research and it affects your reproductive stuff. So we've seen like a lot of females in the fire service, which concerns me that are they passing this stuff on to the children? We've seen a higher rate of testicular cancer in firefighters. That's when we started wearing the 2-piece ensemble. So
You heard that was one of it?
yeah. So that's my ask. I know this is big. I think it's time that we have a seat at the table. We cut industry out. Let firefighters decide what is safe. And I know there's going to be some controversy because it is a bill that's going to mandate change, but we're realizing that to initiate change, we got to take it on the state level. When we mandate that we want to get PFAS free by 2027, 2028, it's going to force the industry to make the changes that they are well capable of doing. So
Thank you. This
All
is
right.
great. Yeah, and I'm gonna ask Michael a question after you
all right. And I'll email it to Kiki here.
Senator Douglas has a question here.
Sure, absolutely.
Yeah, would you mind sending us the studies that are looking cancer to the people?
Sure. So I can give you some sites. So there's NIST has done a study on it. I'll give you all that info too. Another one out of Duke University. I can also give you the link to the IFF. We have a whole thing. There's a PFAS-free deal website that goes over.
Send that in with your
I
test.
can send you a list of stuff, and I'll
Because
also
the
send you.
Commissioner of Health also had some of that.
And I can also forward you the link. We had a presentation in Monday that they set up. One was with the guy from North Carolina, so you can see what his spiel is. It easily sells you. I'm going to ask you not to focus on the test. Afterwards, there's one we did with the IFF that kind of lays it out. There's some flaws with this test. It's not realistic. It's meant to skew that. But just to give you, because I'm firmly, you got to look at both sides and see what they're telling you. But yeah, I can certainly give you, I can flood you with information on PFAS and that connection.
Okay, we got to move along.
All right, thank you very much.
very much. Yeah. Michael, can you remind me what we did with the firefighter equipment in our previous lives?
For PFAS or,
For what was for other toxic, was it for PFAS or what? What was it for?
for PFAS, you did not require the phase out. You required a notice requirement.
Oh, that's right.
The manufacturer,
Yeah.
the seller needs to provide notice to the buyer
Yeah.
of the presence of PFAS and provide information related to the health risk.
Okay, all right.
Now you ban brominated flame retardants in
Electronic.
and TEs.
Yeah,
And in general products, no person may offer for sale, distribute for promotional purposes, or sell at retail a product containing octa BDE or penta BDE. But I think probably what is happening is it's
There's
other.
something else. yeah. All right, we'll have to think about this one. Thank you. All right, well, so let's keep moving. So Bill Driscoll is here. Thank you for being here, Bill.
What are you missing?
All right. Do we have testimony from that?
I'll be following up, right?
Please, okay, that'd be great.
So thank you, Madam Chair, Committee, for record, William Driscoll, the Associated Industries of Vermont, representing the manufacturing sector. We've been actively involved in debates over PFAS and other chemical builds over the years. We try hard to pull together all the various industry stakeholders to try to get consensus input and try to work with the legislature to try to find a compromise way through on things, often with regard to chemicals, in particular PFAS, where there's extensive efforts to try to remove it from products. It's really a question of timing and flexibility in some of the provisions, not whether or not we should move away from the chemical. I think we've been fairly successful, I think, in finding common ground on the last several rounds of legislation, and we're hoping we can do so with this one as well. We do have some concerns with the current state of the legislation. Some are relatively minor or technical, and then there's other that are a little more substantive. To go kind of more or less through the bill, there are some definition issues which I think are worth flagging for further consideration. Dental floss, there was some debate or discussion in the House committee about the definition and making sure that we're covering what we need to cover and not have unintentional consequences. And we are concerned, we're trying to run it down a little more carefully, but the concern is that the definition of dental floss includes a string-like device. And I think in people's mind, that's traditional dental floss as you imagine it. However, there are electronic flossers, including one that I have myself, which does use string. It's not a pick or something like that. And that raises the issue not about the floss itself, which is PFAS free. In fact, they advertise it as such. It's the internal battery and the wiring and whatnot, which makes that analogous to juvenile products, which has an exemption for internal electronics and stuff like that. So I think it might be
Well, but,
necessary.
okay, so you're suggesting that, what would you add here since it's?
I think we look at something similar to the language for juvenile products. It's just
Oh.
accepting internal
If-
electronic components.
If we feel it's necessary.
Yeah.
Yeah.
And then another one has been pointed out by some folks that the definition of fluorinated containers is a little circular and not as technical as it probably should be. However, my understanding is Maine is addressing that through its rulemaking, so it may not be necessary to fix it in the statute. Just want to flag it. I'm going to try to touch back to folks more and see if they want to offer a more technical definition, or if we can have the understanding that it'll be addressed through guidance or whatnot. I think Mike O'Grady already identified when his walkthrough I think inadvertent dropping of residential when it came to carpet and rug. So obviously we'd like to see that restored. And
Where is that? Which one is it?
where is
It's in the prohibitions.
Subsection 8. Page 8.
8, what?
Page 8, subsection 8.
Page, just on the page.
8.
Oh.
Oh, yeah.
I was on page 2. We were back on page 2 and then
Well,
jumped to page 8.
It's a general, yeah.
We got it. Okay, I see it. All right.
There will be a little jumping around.
Yeah, I got it. Okay, there you go.
So I would make the pitch on the definition of PFAS. Obviously, when we were considering a much more ambitious, broad scope of a bill, the need to refine the definition of covered PFAS was especially important. With the much more narrow scope, at least of the bill as it is now, it's perhaps less, but we do think it would be important to begin to work into the definition of PFAS, the concept that not all PFAS is the same. The original proposal from the 131 report was a more limited scope, but also the ability of the relevant authority at that point of the ANR, I guess now it would be the AGs or someone else's, to either add or subtract different kinds of PFAS from being covered, because there's some, whether you're talking about HFOs.
How many thousand chemicals are we looking at? This is one of the.
Right.
Which we have, yeah.
There are variations of PFAS that are either less of a health concern or more important to critical technologies, like trying to phase out HFCs or HFOs. Fluoropolymers are a whole other category of PFAS that doesn't have the same health concerns, but also important uses, which might be difficult to find alternatives. So we would just make pitch to at least have that authority in the bill to expand or contract the universe of covered PFAS, as was originally proposed in the 131 report.
Through the ANR. Got it.
I think it'd be Matt personally would be in charge of it. So,
Okay. Thanks. Got it.
always looking
Our
out for you, Matt.
expert. Okay.
So those are some, maybe a little bit technical ones. The more substantive concerns, and this has really been one of the biggest concerns of industry so far, is expanding the definition of intentionally added. Right now, the expansion is not as great as earlier in the process, but it's still of concern because when you're looking into the manufacturing process, there's been a lot of work and a lot of sort of confidence in the ability to find alternatives to PFAS in the list of products. The manufacturing process is a much more untested area. Only Rhode Island has put a processing contamination on the books. I'll make a minor note, Vermont, as you know, Madam Chair, did a very specific thing for artificial turf. But that was kind of very unique and focused just on that one product. Generally speaking, though, nobody has intentionally added covering the manufacturing process. So the confidence that we'll be able to have alternatives or run into unavoidable use issues is not there for that area.
Are there specific industries that are concerned about that?
So we've tried the fact that down. I mean, it's more generalized. I mean, there's so many different ways that it can be used.
That's one.
And the scope and the scope,
Yeah.
I mean, to the credit of the House Committee and Ledge Council and other folks who worked on this, it was certainly narrowed a bit. So, you know, it has to actually, you know, result in PFAS in the product and things like that. There were a lot of concerns earlier around, and it was much more loose and whatnot. But still, it's a concern. So there's a couple ways that we would recommend addressing that. I mean, ideally, we would keep the definition of intentionally added that we have always used and that all the other states use of serving a function in the product. And then incorporate in the ANR reports back to the legislature, hopefully with having experience with what happens in Rhode Island in 2027, as to whether and how to incorporate the manufacturing process into intentionally added, rather than, you know, putting it as it stands now. Rhode Island and Vermont will be hitting that at the same time without experience as to how that's going to end up playing out. So we just prefer a little more caution and be able to look before we leave in terms of what the impact would be. Other alternatives could be, you know, pushing the date back a bit so that Rhode Island goes first, frankly. And we see
What
what
would the
happens.
date be from your perspective?
Well, so Rhode Island is 2027, so I would ask at least 2028, if not a year or more, to give time to be able to analyze what happened. But that's also segues into another possible way to address this, and that is with the just before we leave, intentionally added. Very much disagree with the recommendation of the AG and NR to go to using water quality standards and test to whether or not water is exempt. The House Committee explicitly considered this and decided to go back to the language that is in the bill now. Part of the rationale is that there really is no logical correlation between the water quality standards and how water may or may not interact with products during the manufacturing process. And the whole point is to make sure that because PFAS and water may be entirely out of the control of the manufacturer, and most manufacturers can't simply find another water source. If there's contamination that is outside of their control, that's really something that's very, I mean, it could have pretty catastrophic effects on the ability of the manufacturer to operate if that was allowed to continue.
Got it.
And this was certainly an area, again, that the House Committee talked about quite a bit. So we would encourage to stay with the House language on that.
Language.
In the bill. Yes.
Okay.
They did talk about it.
Yeah.
And decided to go. with-
Got it. All right.
So unavoidable use.
So how many more things have you got? We're moving into other time frame, and you're gonna send us this stuff.
I'm very happy to come back.
No, I want you to finish up, but do it with as quickly as you can.
Yeah. So unavoidable use
We got
exemptions.
Where is that?
Unavoidable use,
Yeah.
So this is more conceptually. So right now,
okay.
there is an unavoidable use exemption in here for fluoridated containers.
Yeah.
Unavoidable use exemptions are common in other states that have these sorts of laws, and unavoidable use exemptions were part of the original 131 recommendation.
Mhm.
Now, I'm sure, as Matt or others would point out, that was in the context of the broader consumer product ban.
Mhm.
And I think in part because that's going into more untested, unexplored territory where you could very well run into situations where there are not alternatives. And so folks who would oppose having that exemption for these listed products is that there should be more confidence that there are alternatives to these products. And I would generally agree that there will be. I don't know if we can be entirely confident that we will definitely meet the timelines. But the issue is that there are two areas where this bill goes beyond what it is commonly addressed in other states and where there's greater confidence. The first is in fluoridated containers. I would suggest there is still a great deal of concern among industry about potentially unavoidable uses. I think there's a disagreement about the extent to which federal regulations effectively require fluoridated containers. The point is that is an area of uncertainty. Only Maine has specifically gone after fluorinated containers before 2032 or a broad ban. So again, it's untested territory. Maine has exemptions for various federal regulations, other things that limit what it would do, which are not here in this proposal. So we recommended, and the House Committee agreed to include this mechanism as a safety valve just in case. And whether it's complicated or costly or whatnot, it's only going to be used if it's necessary, and that'll obviously be part of the consideration of the industry or whether or not they want to ask for one. I think the idea of pushing the date back more and maybe having some process to tackle the questions of costs and how the mechanism will work would be certainly reasonable. If you want to look at 2032 and have reports in between or something, I think I'd be happy to follow up more with A&R and others to kind of talk through that more. Frankly, we were satisfied with what was included in the House. But the other area where an unavoidable use exemption would be important is because intentionally added is at least currently including the manufacturing process, and we have uncertainties about that. It would be important to have that option available from 2027 or whenever. We cannot find alternatives for some manufacturing processes. There should at least be a mechanism there to be able to address that. And so we would encourage not only retaining the unavoidable use exemption in the House passed bill, but having that applied for intentionally added as well. Again, we don't know if we're going to have to use it, but it'll be a bit of a trailer if we need it and we don't have it. So this would strongly recommend that. Finally, I'll just touch on, I know some other witnesses are going to address, there were a number of exemptions in the original proposal, some of which we think should be restored. Most importantly, there was an exemption for products with 50% recycled content. That's sort of balancing the interests of removing and preventing PFAS circulation, but also of encouraging recycling. And, those two are not necessarily, there's a little bit of a Venn diagram there. And so having an exemption for certain fluorinated, certain recycled content would be important. And again, I think at least one or two witnesses coming can speak more to that. And generally, we like the original proposals had an implementation date of July 1, 2028. And we've heard specific feedback whether moving up to 27 it's going to cause compliance issues or not. But for what it's worth, it's always nice to have more time. So consideration of the original date would be great.
Which was 28. Okay, I think so. What we would like is for your testimony in writing.
Yeah.
So we've already gone over.
Well, if I could finish address the firefighting.
You can finish by 1:15.
Excellent.
There you go.
Generally speaking, yes, there is great advancement in finding alternatives in clothing for firefighting equipment. Where there are not alternatives necessarily is in equipment like respirators and things like that. We have gaskets and other sort of parts.
No, it's been a problem right along.
Washington did an assessment of alternatives, and they found alternatives for clothing, but not for things like respirators. So at the very least, I'd like to separate that out, perhaps. Maybe have some more time added as well. The very fact that we have the notification requirement from S20 already allows sort of consumer choice, if you will, so that purchasers can know what they're buying. So,
Quick question for you. How many manufacturers use PFAS in the state of Vermont?
oh gosh, Can
you find that for us? I mean, because you are theoretically representing.
most of them are
Vermonters.
phasing them out. I think actually you can probably, just as one example of covered area, I think when Kelly all testifies, she can talk about how that
Right. No,
industry is in a
it would
process.
be helpful just to know that. I know a couple in my district, but it would be helpful to know how broadly PFAS continues to be used in the manufacturing process for the products that we're talking about here.
Oh, the manufacturing
Yeah,
process.
all of them.
Yeah.
Yeah, whatever.
Well, certainly if you look at things like fluoropolymers, which are very stable.
Right.
Those are pretty
No,
well
just
used.
send it to me. This is good. I know. We could get into a long conversation.
You
And I could, I know. We'll do that. We'll do it. I appreciate your time,
All right.
really very much, and thanks for your comments. And we'll get them, so we have them. All right, so Kelly All is here from the Why don't you introduce yourself? Thanks for being here.
Thank you. For the record, I'm Kelly Alt, Executive Director of the Vermont Outdoor Business Alliance. Thank you, Chair Lyons, and the members of the committee for inviting me to share our support of H238 as we convey our support at 131. To reintroduce VOLA, we are a nonprofit with a mission to strengthen Vermont's values-led outdoor recreation sector balanced with environmental responsibility. Our 150 mostly small business members drive local economies, support healthy lifestyles, and protect natural and recreation resources. Vermont's 40 apparel manufacturers and 60 outdoor retailers could be affected by H238. Those Vermont businesses are fully committed to phasing out the intentionally added PFAS in apparel that has historically been used to protect users with qualities like water repellency, durability, and breathability. Manufacturers have been working hard for years to transition to non-fluorinated materials and have invested significant corporate resources in research and development, supply chain adjustments, production technologies, and consumer education. In consulting with Vermont manufacturers, which operate at the national and global level, retailers located in our communities, serving resident and visitor outdoorists, and in working with national outdoor industry organizations, we ask that Vermont's PFAS law provide predictability, consistency, and be in alignment with laws in other states, such as California, New York, Maine, and Colorado. Our recommendations for H238 to make phase-out goals achievable include 3 areas. We do support the definition of intentionally added in H238 as aligned in other states, and that it doesn't make manufacturers responsible for byproducts or impurities from cross-contamination, which is beyond their control. The second issue is reinforcing the deadline of July 1, 2028 as adequate for the outdoor industry. And there are several reasons. The first is that it makes compliance with the 50 ppm total organic fluorine limit by manufacturers, both large and small, that operate in multi-year production cycles of sometimes 18 to 24 months possible. Secondly, it allows for a retail sell down of already produced inventory to ensure that products are not destroyed by landfilling or incineration all at once, and preventing the stranded inventory from becoming a source of significant pollution is compounded by also limiting economic harm to our small retailers in our communities. The last reason is that 2028 includes the need for express language on apparel designed for severe wet conditions, which matches timelines in California and New York. The last reason we wanted to make a recommendation is around adding back language exempting products with at least 50% recycled content to address the problem of textile waste. New apparel requires intense resource use from raw materials, including fossil fuels, water, land, and chemicals. VOBA shares circularity goals with the state and supports the outdoor industry circularity movement in recycling, repairing, resale, use, reuse, and sustainable disposal. And we know that more time is needed to develop the nascent nature of textile recycling technologies and systems. We know that current testing data for regenerated textiles reveals a 15% failure rate at 50 ppm TOF. And we also know that states like California are fast-tracking processes by developing regulations, establishing procedures, and directing funding for textile recycling and reuse. The Responsible Textile Recovery Act in October of 2024 passed in California, established the first extended producer responsibility program for textiles, apparel, footwear, and travel goods. It addresses collection, infrastructure, technology development, and requires textile producers to take responsibility for their product's entire lifestyle. Similar bills have been introduced in New York and Washington. We feel that including an interim exemption for recycled content will allow Vermont to benefit from regulation setting in other states and improve industry infrastructure across the country and in Europe, both incentivizing phase out and circular economy. So in summary, VOBA and Vermont's outdoor businesses are dedicated to sustainability and continue to leverage corporate resources for social impact. A Vermont PFAS phase out that is aligned, predictable, and consistent with other states enables our best business stewards of Vermont's health and environment to prosper. Thank you for your consideration of VOBA's recommendations for H238.
Thank you. Questions?
This is a comment.
Okay.
And Kelly, this is not geared just to you, but just generally when people come in and give testimony, I always find it a little confusing when they start with, we support this bill. And then they go on to like say all the things they don't support that they want to change. I just wish it could be a more nuanced opening statement, you know, because actually you don't really support the bill as it is written right now.
Well, thank you for the
Yeah.
feedback. That's helpful. I just
It's
wanted to
everybody.
convey in general that the industry supports the phase out of PFAS, and overall we do support the bill. And the first two comments are really reinforcing what's in the bill. It's the recycled content piece, as you pointed out, that is something that is not in 2 through 8 that we would like to see involved. So maybe a more, maybe framing it more.
Happens all the time, and I
That's
just
great.
find it interesting because I'm always like, oh, great, they support it. No, not really, but yeah, thank you for that very much.
Thank you. Try to turn my back and you're looking for some information as you were talking. Appreciate it. So we'll move on to Steve Burns from Cookware Sustainability Alliance, and Steve is here on Zoom. Good morning.
Good morning. Can you hear me?
Yes, we can. And I
Super.
think you have your testimony online. Is that accurate?
It's going to be submitted as
It's
soon
not
as I
here
finish.
yet. Okay, well, you will get it for us. Thank you.
Yes, of course. And I'll go through this quickly, Madam Chair and committee, and thank you for allowing me to come in via Zoom. I know I'm the only one on this panel doing so. I do represent the Cookware Sustainability Alliance, which is a group of the larger companies that produce all types of cookware, but specifically for this conversation, obviously, non-stick cookware. And we were formed last summer. And I say that as a data point because that was after you passed and your governor signed S25. So we weren't able to engage in that conversation. And I regret that, but I do appreciate the opportunity just to bring a few points forward today. As Bill Driscoll said a couple times, the chemical that we use in our products, and I think you know this, Madam Chair, very well, is fluoropolymers, and it's one of the more than 14,000 different chemicals, although I think I heard somebody say there might be 7 million different chemicals. Mr. Chapman, I don't know if he was saying it in the same context, considered PFAS, but fluoropolymers are, in our view, and in the view of most of the science that I've seen, very, very different than, for example, a PFOA or PFOS. Fluoropolymers can be hundreds, if not 1,000 times longer than a PFOA molecule. And the result of that is their length and their weight allow them, and they do pass directly through the human body. They don't bioaccumulate. And importantly, they're not water soluble. They cannot get into the drinking water system. And that obviously is the way that most PFAS of concern are consumed by Americans and anybody around the world. And a lot of studies have shown them to be non-toxic and inert. So when we come forward to talk about cookware, we want to differentiate the type of chemical that we're talking about. And it's called PTFE sometimes, but I use the broader term of fluoropolymers. And there has been some attention given to this, and I think it's valid that the production of fluoropolymers historically has involved PFOA and probably PFOS as well. And there are some very famous cases where there is ongoing litigation in West Virginia and North Carolina, for example, happen to be Chemours plants where they produce fluoropolymers and they produce other chemicals, but mostly fluoropolymers. And there is instances there of PFOA having found its way, unfortunately, into drinking waters in surrounding communities. PFOA was voluntarily stopped as an ingredient, as far as we know, by these companies as far back as 2013, and it's never been used by our industry, the nonstick cookware industry. So connecting the unfortunate production processes of the past that made fluoropolymers with prospective bans of our products or any product that uses fluoropolymers for that matter is something that gives us a little bit of concern, because we do think our industry and just about every industry that comes before you has significantly changed how they do business. The final point I'd make is that the other area of concern for non-stick, i.e. fluoropolymer coated pans, is in landfills or in end of life. Just last September, a German independent refereed article came out, which gathered a representation of about 80% of the commercial fluoropolymers. And what does that mean? They gathered samples from the aerospace industry, from automotive, from HVAC systems, from solar panels, and they put them through the incineration that happens in industrial incineration up to 1,000 degrees Celsius. And in just a very short period of time, the fluoropolymer coating in all of those products, including cookware, was completely mineralized. It was inert. They tested it afterwards. There was no leaching. There was no signs of PFOA, et cetera. And this is the first time this has been shown. As I said, it was just last September in Europe. So the end of life issue, when you combine that with the fact that the fluoropolymer molecule is inert and cannot be water soluble, we just don't see that there is a danger of it getting into a landfill and at some point in time breaking down and entering into the water table or the water supplies. The Food and Drug Administration has authorized the use of fluoropolymers specifically for cookware since the 60s. The European Food Safety Authority does so. The governments of Japan, of France, of Germany, and just last month, the federal government of Canada placed the entire PFAS group into what they're calling their EPA, their Environmental Protection Act, and they're going to do a risk management program of all PFAS chemicals, as we said, somewhere between 14,000 and 7 million of them. But the Canadian government specifically excluded the fluoropolymer class. So they took it out at the very beginning because they said, and this is their quote from the Canadian federal government, they do not meet the criteria of substances that are entering the environment in a quantity or concentration under conditions that constitute or may constitute a danger to the environment on which life depends. So it's not just the United States Food and Drug Administration. There are a number of regulatory bodies around the world, as close to Canada or in Europe, which has reached the same conclusions as we would like this committee to consider. And here's my final point. You asked for whether we support the bill or not. We absolutely support the bill, and we support it because coming out of the House version was a 2.5-year continuation to address cookware up to July 1st of 2028. And that's really important for the industry. As I said, we do believe our products to be safe, but we understand the regulatory reality that's occurring in this state and around the country. We're desperately trying to find the next iteration of nonstick coating. Between 60 and 70% of pans and bakeware that is sold is nonstick, so it's a vast majority in everybody's kitchen and in commercial kitchens around the country. It's going to take some time, but we're looking hard for the future and towards the future. So we would very much appreciate your support for that continuation as we as an industry continue to act responsibly and look for the next iteration of our products. And I thank you very much for the time.
Thank you. Very helpful. And please do get us your testimony so we have it for the record. It'd be very
happy to. Be happy to.
Questions for Steve Burns. Okay. Terrific. Thank you.
Thank you.
Anna Superling is here.
Hi, good morning. Great, thank you so much for having me today. Madam Chair, members of the committee. For the record, my name is Anna Superling, the environmental advocate with VPIRG. testifying on H238. Since this is, I think, VPIRG's first time in the committee, just a brief introduction. VPIRG is the Vermont Public Interest Research Group for the state's largest environmental protection and consumer advocacy organization, with over 20,000 members across the state. And for 50 years, we've been advocating to protect Vermont's environment, public health, and democracy. We've been closely following Bill H238 and are largely supportive of its efforts to reduce Vermonters' exposure to PFAS chemicals. So recognizing that I have maybe 10 minutes or so, I'll briefly go through my points and answer any questions that you all have. So I know you all heard from the Department of Health earlier this week, but just to reiterate why it's so urgent that we handle PFAS pollution is that PFAS exposure has been linked to some serious health concerns, different types of cancers, liver damage, reproductive health issues. And Vermont has largely recognized these risks. So the legislature has taken an upstream approach to reduce PFAS exposure, mostly by taking a product category by category approach. So to reduce the source of PFAS pollution in consumer products. So over the last several years, between Act 131, which has been referenced a couple of times today, we've banned PFAS from, as you know, a long list of consumer products. And H238 we're greatly appreciative of, since it just adds that list of dental floss, food containers, and cleaning products as well to reduce the exposure. So yeah, we believe this is another meaningful step towards taking care of PFAS pollution. As you've heard from previous witnesses, this bill has undergone some bigger changes since its introduction in the House Environment Committee. Initially, the first draft of H238, per recommendation of ANR, proposed a broader regulatory program that would have banned intentionally added PFAS from nearly all consumer products, which would have, again, reduced PFAS exposure to Vermonters. Ultimately, the committee decided not to go with this regulatory program and instead continue the product by product strategy set up in Act 131. And because H238 follows the same strategic approach, a lot of the original language was retained, most notably the definition of PFAS. So just to summarize, broader regulatory program set aside, continuing to add products to that list, and maintain that strong OECD definition of PFAS. And I bring this up to you all because you have heard requests from industry to change the definition of PFAS. And I really want to emphasize that this is unnecessary, not backed by science, and would set Vermont apart from 23 other jurisdictions here in the States and the OECD, or Organization of Economic Cooperation and Development. We've seen this requests made across the country, to exclude an entire class of PFAS, fluoropolymers, as you've heard. Industries are looking to undermine states' PFAS bans, like New Mexico, by doing this, exempting fluoropolymers. We do not think that preemptively exempting an entire class of PFAS would be helpful, and in fact, really allow harmful chemicals to remain in widespread use indefinitely. I'd like to preface that I am by no means a scientist or a chemist, but I'm happy to let you know why we're concerned about the health impacts of fluoropolymers, and just let you all know that the House Environment Committee heard from some scientists that were really great and could go into far more detail than I can about these impacts. But to briefly review, we're concerned that fluoropolymers are problematic because their manufacturing process creates a lot of harm. The production of fluoropolymers releases dangerous byproducts into the air and water, including chlorofluorocarbons and CFCs, which are potent ozone depleting substances, as well as HFCs, which have a high global warming potential. So it's that manufacturing process that is harmful. It's also the fact that fluoropolymers and PTFE can have can be exposed to consumers in nonstick cookware. So PTFE can flake off cookware when we use the wrong tools on it, for example, or scrape off, becoming microplastics that consumers ingest. PTF particles have been found in urine and semen with links of reduced sperm counts as well. So again, health concerns from exposure and continued environmental contamination as well when they shed off of these products, enter the wastewater and accumulate in our environment. Finally, new research has shown that polymers, including fluoropolymers, can act as a Trojan horse for toxic chemicals that they may appear stable at first, but degrade over time, releasing harmful PFAS into our environment and our bodies. So the bottom line is we strongly oppose any changes to the PFAS definition, particularly those that would exempt fluoropolymers. I have submitted to Kiki, and it's on the your committee page as well, a letter from various medical professionals and public health organizations talking about this very issue. So feel free to look at this, and I'll also be sending in my written testimony, immediately after this, with plenty of links for you all to explore as well. Briefly touching on timelines, kind of speaking of cookware, the House took testimony and decided to move back the date for cookware. We are not very compelled by their arguments and unpersuaded that there's really any need to delay action here. As you all know, there are plenty of alternatives to nonstick cookware. I myself use a cast iron pan and stainless steel, for example. And maybe more importantly or more relevantly, many other states have the same, if not sooner timelines for cookware. So, for example, Minnesota, starting in this year, the cookware industry will not be allowed to use PFAS, and then Maine and Colorado have our original dates in 2026. Moving along, we agree with the Attorney General's suggestion to move along with water quality standards that hold out-of-state manufacturers accountable and maintain our water quality standards as well. We think that this is a great way to protect Vermonters from PFAS. Great. And then one piece on fluorine treated containers. We're very interested in getting PFAS out of the containers, especially those that hold the products that we don't want PFAS in. So we're hoping to have further conversation with the AG's office and stakeholders and kind of get some more answers and insight on to what exactly this would look like. But generally, we're supportive of the language that's currently in H238. So I'd like to conclude and just thank the committee for taking up this bill and the hard work that you're doing to take swift action to reduce Vermonters' exposure to PFAS. H238 makes significant strides toward this goal. And then lastly, I just want to acknowledge that there are some important aspects of this issue that are not in this bill. Firefighting gear, for example, we see it's important to protect our firefighters from PFAS while ensuring that we don't move to other unsafe alternatives. And then finally, PFAS contamination, as you all know, extends to pesticides and PFAS and biosolids, and is a serious growing issue, not only in Vermont, but across the US. Vermont should certainly be developing a plan to deal with PFAS and biosolids and pesticides. And while it may not be in this bill at this moment, these are, of course, critical issues that we strongly encourage future legislation or studies to look into and explore potential solutions, as Maine and Connecticut have already passed some biosolids regulations, wondering, what can we learn from that?
That is an ongoing issue, isn't it?
Yes.
Something I've been thinking about myself.
Yeah, certainly. Thank you so much again for your time.
Do we have everything of yours?
Yeah. I will send this.
Yeah.
Immediately afterwards. Yes.
Senator Blue.
Thank you, Anna. This is not related to health and welfare, actually, but every time I have an audience with paper, I have to say this, you are the Vermont Public Interest Research Group. One of the most important issues of public interest is public education. I wish you guys would pick up that mantle.
Yeah. Thank you. Appreciate that feedback.
She's always advocating.
Well, always on it.
It's okay.
It is.
Questions Committee. Thank you. Thank you
so
for
much.
being available to us.
Yeah, certainly.
So we are going to take a break at this point, and we do have folks, coming in around, Act 115 that we passed last year. And, Kiki, are they available earlier? Are they online?
Yeah, they're all.
They're online, so we won't take a break at this point.
Very well. I've used this room.
Okay.
I'm gonna take a break.
And we'll just hear from them very briefly, and then we're going to adjourn for the day after this. Thank you all, appreciate it. And if you haven't, please get your testimony to us. Thanks, Matt. Everybody else is on the screen with us. Kelly, do you mind closing the door? Thank you. All right, so we're moving on to, here's some folks. So I'm asking, is it Lynn, are you in charge? Who's in charge?
Yes,
Coordinating,
I'm as much in charge as one can be in charge.
as much as one can be, was it?
Yes.
Join the club, so, we would like to hear from you. We're not gonna spend more than 10 or 15 minutes.
Yep.
And it would be very helpful for you to just sort of introduce the topic and yourselves, and then your report.
Perfect.
Have a
If I
seat.
can connect to,
Yes. So you gotta go to Zoom first and then you link in.
yes.
Excuse me. Sorry.
Okay.
Just if you have your sound off, then it won't reverberate.
Thank you.
Yeah.
And I'm hoping that I can share my screen. One sec, I'm just joking. Oh, look at that. I'm always surprised when these things work. Yay. So thank you for the time to set
I
this up.
think I think you have to hit the X, so then we'll see the, up on that screen. Is that right, Kiki?
That is on Lynn's.
That's on your screen. You have to hit the little X on your screen. Exit out.
But
Whoops.
yeah,
Took care of that one. Okay, go back to it and then maybe there's something else you need to do.
it's a different.
I think hit enter full screen.
When I get to the screen your audience is looking at to enter full screen. The thing is, I'm not seeing that on my.
Maybe if you click on that purple thing. On the window, little purple enter.
There is no purple thing on the screen.
It says, well, then let's try it up on our screen. Can you just touch the X up there? Touch the X. See what happens.
Or the purple box.
Yeah, purple. Then, Oh, share contact. Okay.
Yeah. No. Did you do what's other?
I apologize.
No, it's just.
It works.
It's your computer. It's your computer.
All right, well, we'll listen to your report. We have it on do we have it on our webpage?
You will.
Okay, that's fine. Just go right ahead. We're good listeners.
Okay.
We are.
I'm just gonna do the other mode. There, okay. Look at that.
That's the one you
Now I'll just, yes, but now I'll just be reading from here. rather
That's
than my
fine.
screen.
That's fine.
So-
We're good.
Thank you so much. My name is Lynn Career Stanley. I am the Executive Director for the National Association of Social Workers, Vermont chapter. And just as a background, Act 115 came about last year because a few years prior to that, I got a call from Alex Margulies, who is the partner of Leah Rosen Pritchard, who's the social worker who was killed by a client a couple of years ago. And he asked, is there anything that we can do? And I said, let's see what we can do. And so last year, we said, can we bring together a task force to look at the problems, look at the issues, and make some recommendations about what we might do for it. And so last fall, that's what we did. You'll have the list of all the contributors in the presentation. And this is the fruits of that labor. When people don't have their basic needs met, shelter, nutritious food, physical and mental health care, they're at increased risk for a variety of individual and societal challenges. According to 2023 data, 9.7% of Vermonters live below the poverty line. In our state, over 75,000 people are facing hunger. Over 16,000 of them are children. In August of 2024, 51 out of every 10,000 residents were homeless, placing Vermont second only to New York for the highest rate of homelessness in the country. Homelessness can amplify poor mental health. The stress of homelessness can increase mental health symptoms and substance use. Malnutrition can exacerbate not only physical problems, but also psychological challenges such as depression and anxiety. Children growing up in poverty have a higher risk of developing a mental illness. Poverty can increase the likelihood of mental illness through disparities in perinatal risks, malnutrition, trauma, social marginalization, and violence. The Cohen Veterans Network found that there's a large disparity in access to mental health care based on level of income and location. 42% of people found poor insurance coverage as the top barrier to accessing mental health care. Provider workforce shortages, transportation, and inadequate insurance coverage are all barriers to people accessing needed mental health care. While violence by a client against a social service provider is never excusable, given a lack of resources, increased stress levels, and increased mental health challenges, it may be more likely to occur. Meanwhile, social service providers connecting clients with resources, working to alleviate symptoms, provide mental health care and other services can find themselves in unsafe situations. The Occupational Safety and Health Administration, OSHA, found in one survey of 175 licensed social workers and 98 agency directors, 25% of social workers had experienced assault by a client. Nearly 50% had witnessed violence in the workplace, and more than 75% were fearful of violence occurring. In a study of child protective service workers, high levels of what was termed non-physical violence, such as yelling, shouting, and property damage, was experienced by 75% of child protective service workers. Physical violence was experienced by 2.3% of workers in the first 6 months on the job. Quality of service to clients is compromised when service workers are experiencing exposure to violence and burnout. Attention to safety in the workplace can reduce the level of burnout and help with staff retention. Of particular note is the correlation between transitions and risk of violence. The Vermont Department for Children and Families found that over half of the violent incidences occur within the first week after child removal, in the time between a child being removed from the home and the first visit with a parent or caregiver. Other transitions include the period of time immediately before and after a survivor of domestic violence leaves an abusive partner, where the risk of retaliatory violence against a survivor is significant, as well as a client returning to the community after being in residential substance abuse treatment, or when a client is transitioning from one agency's service providers to another. This might indicate a greater need for a safety net, increased communication between service providers, and more detailed planning. While we are concurrently addressing access to resources, increasing our workforce, and closing system gaps, we must also mitigate the risk of physical and mental harm to our social service providers. We contend that these issues must be addressed concurrently, as this is a circular problem. Lack of services and resources contribute to increased violence, and increased violence contributes to the lack of social service providers. The group identified training and systemic supports as key to keeping workers safe. New workers need training in their client population, agency policies and procedures, safety protocols, and de-escalation, so they do not exacerbate or create conflicts or contention. All workers need ongoing in-service training to address changes in the environment in which our direct workers are operating. Supervisors and leadership need training to support their direct care workers. While this is true, and this is one of those points that I really want to drive home, we do not want to encourage the myth that if a social service provider was quote unquote good at their job, they would be able to talk their way out of any challenging and potentially violent situation. Social service provider training, as found by OSHA, cannot be one size fits all. So much depends upon the client population and where services are provided, whether inpatient, in office, in the home of the client, or within the community. Safety protocols will and should look different. Systemic supports within an agency and between agencies might include scheduled check-ins, recognition, and support during client transition times when there is increased risk, and bolstering infrastructure to include self-service capacity, websites with resources, or panic buttons, all depending on the setting and client populations. There are a number of barriers to ensuring social service providers have the training and systemic supports that they need to increase safety. First and foremost is the cost of evidence-based safety training, the need to tailor the training to the setting, bolstering infrastructure, and providing quality supervision and oversight. Possible recommendations include expanding some of the private-public partnerships for training we are already seeing in some milieus. Institutions like hospitals are doing safe workplace violence prevention and safety training for their employees. The Department of Children and Families, Family Service Division is already doing safety training for its workers who are in people's homes and within the community. Smaller agencies can partner with these larger organizations to have their staff sit in during these training times. We also highly recommend that volunteers and support staff are included in these safety trainings. Finally, we recommend grants for smaller organizations and agencies to conduct needs assessments and pay for training and improvements to infrastructure. Our workers provide invaluable services to our most vulnerable populations. They deserve to be safe and supported. Vermonters deserve to have their basic needs met, often with the support of these social service providers. And there's our list of contributors. And I need to also give credit to my student interns who did a lot of research.
Did a lot of work. That one little bill.
It's great.
Thank you. This is a good start, isn't it?
It
For you.
is, it is a good start.
Yeah. no,
It is a
big
good start. I'm happy to answer any of your questions. I really do. Some of what was striking to me in these meetings really was the evidence that shows the higher risk during those times of transition, when it is the most tenuous for clients, just in general, and then which contributes to potential violence against social service providers. That's about
Perfect. Thank you. Right on time. And we will have your information, and then going forward, if there are legislative initiatives that you feel are important, we'll welcome.
mini grants would be ideal.
Yeah.
Yeah.
Thank you very much for your time.
Thank you.